Good morning. This hearing will come to order. I want to welcome everyone to today's hearing titled VA and Human Tissue, Improvements Needed for Veteran Safety. This hearing focuses on VA's continuing problems with the tracking and management of biological implants, which include skin grafts, bone grafts, heart valves, tendons, and other products that use human tissue. In a previous hearing in January, this subcommittee examined continuing issues regarding prosthetic procurement, in particular VA's over-reliance on open market purchases that are potentially the most expensive procurement method and may pose the greatest risk to patient safety. VA contends that waivers are necessary to accommodate clinician preference for products with which they are familiar. However, our investigation of this billion-dollar industry shows that there may be ulterior motives. In this regard, over 57% of biological implants are procured by VA as open market purchases. And we have found that several VA clinicians serve on the board of directors of at least one of the major suppliers to VA of biological implants on the open market. VA's failures regarding biological implants go well beyond possible conflicts of interest in procurement practices. Our investigation reveals that the problems include VA's failure to adequately vet biological implant vendors to make sure that they are registered with the Food and Drug Administration and that they are utilizing best practices, such as those established by the American Association of Tissue Banks. Even more concerning is that VA lacks any ability to identify the sourcing of the material used in biological implants and track it from donor to recipient. The lack of such a track and trace system poses very serious and unnecessary risks to patient safety. Although it is very difficult to attribute adverse events to tissue product contamination, one recent example of a contaminated transplant shows the ramifications. According to a report in the Journal of the American Medical Association, the kidneys of an Air Force recruit from North Carolina who died from a rabies infection in July 2013 were transplanted into a Maryland veteran who later died from complications with rabies. Illegal trafficking of human tissue jeopardizes the supply chain of biological implants. A 2012 report from the International Consortium of Investigative Journalists indicates that trafficking in human tissue crosses international boundaries. One of the most egregious examples of such trafficking within the United States is the case of a dentist in Brooklyn who lost his license due to drug addiction and who then created a massive scheme to plunder tissue from funeral homes, including from people who had died of cancer, HIV, and infectious diseases. He would pay undertakers, falsify required records, and then resell the tissue under the business name Biomedical Tissue Services. Significantly, at least one of the alleged customers is a current supplier to VA and has received repeated citations from the FDA for cross-contamination issues. Apparently, VA took no action to address this major safety violation with that company, even after receiving a biological implant from the vendor. GAO and the VA's Office of the Inspector General have documented weak inventory controls that make it difficult, if not impossible, for VA to identify the patients into whom they were implanted. In its written statement, GAO found that VA uses informal tracking systems that are not standardized or shared across departments, and that even when used, are prone to error because they rely on manual data entry. In its statement for a previous related hearing in January, GAO found that for some clinical specialties, including gastroenterology, interventional radiology, and pulmonary, identifying information on implants was not tracked in any system. Given the incomplete and inaccurate data regarding inventory control, serious doubts are raised about VA's ability to identify patients in the event of contamination of a product. Or contamination or a product recall. It is troubling to consider, but in an investigation in March of 2012, VA's Office of the Inspector General found expired products remaining on VA's inventory shelves. Fortunately, the FDA has developed a unique device identification system that if deployed by VA would facilitate reliable tracking and tracing of biological implants. I urge VA to implement this system and to develop an automated inventory controls system that is compatible with the unique identifiers VA needs to make VHA the premier healthcare delivery system it aspires to be. It should lead the nation in the adoption of FDA's unique device identification system for all types of biological implants, even before FDA's implementation deadlines. The 6 million veterans served annually by VHA deserves the highest standards of patient care in the nation. With that, I recognize Ranking Member Waltz for his opening statement.
Well, thank you, Mr. Chairman, and thank you for your continued care of our nation's veterans and willingness to make sure we do our job of oversight. But I'd also like to thank Ranking Member Kirkpatrick for her work on this and for the opportunity to allow me to be here today. We're here to talk about VA's surgical and biological human tissue implant purchases and the ability of VA to safely track these. I'm looking forward to exploring the progress that VA is making in maintaining accountability of implants and what impediments, if any, stand in the way of VA instituting a system-wide policy to verify vendor VA registration. Last year, nearly 60,000 tissue products were used at VA medical centers. Ensuring that these are safe and reliable needs the full attention of the VA and of this subcommittee. Tissue implants can provide amazing relief to the suffering of our veterans, but as with all these technological wonders, there's risks that the chairman mentioned. In January, we held a hearing to investigate VA's procurement of surgical implants. There were a number of shortcomings noted by the GAO, including a lack of an automated mechanism for tracking. I look forward today to hearing about the progress VA is making in this effort and what further steps are required, not only in the area of human tissue, but in the large area of surgical implants and prosthetics. Implementing a system-wide implant tracking system utilizing barcode technology for blood products are important steps to ensuring patient safety. I note that the VA has established a working group to look into improving management of biological implants. I'd like to hear today whether VA can move faster to develop a single comprehensive tracking inventory management system for all biological implants. Finally, I look forward to hearing what system VA has in place so that implants can be tracked and appropriate action taken if the FDA issues a recall. In addition, I look forward to hearing how VA will ensure vendors are registered with the FDA. Last week, we held a legislative hearing on a draft bill, Biological Implant Tracking and Veteran Safety Act of 2014, addressing...
Thank you, Mr. Waltz. I ask that all members waive their opening remarks as per this committee's customs. With that, I invite the first panel to the witness table. On this panel, we will hear from Mr. Philip Matkovsky, Assistant Deputy Undersecretary for Health for Administrative Operations, Veterans Health Administration. He is accompanied by Dr. William Gunnar, National Director of Surgery for the Veterans Health Administration, and Dr. Michael, I believe, Lairdy, National Director of Pathology and Laboratory Medicine Services for the Veterans Health Administration. Please come to the table. Mr. Matkovsky, your complete written statement will be made part of the hearing record, and you are now recognized for 5 minutes.
Mr. Chairman, Ranking Member Walz, and members of the committee, thank you for the opportunity to appear before you this morning to discuss the Department of Veterans Affairs sourcing, procurement, tracking, and oversight of its biological implant purchases, including implant tissue. I am joined today by Dr. William Gunner, National Director of Surgery, and Dr. Michael Accardi, National Director of Pathology and Laboratory Medicine Services. Over the last 8 to 10 years, utilization of biological implants, including implant tissue, has grown significantly, resulting in the doubling of dollar value of the biomaterials market since 2004. However, the field of biological implants continues to rapidly evolve with new advancements in tissue fabrication, nomenclature standardization, and industry governance. In procurement, VHA recently completed its transition of procurement duties from prosthetics purchasing agents. This transition resulted in the removal of warrants from staff who were not contracting officers, and procurements above the micro-purchase threshold are now performed by our contracting officers with warrants. While Title 38, Section 8123 grants broad authorities to the Secretary of VA for the procurement of prosthetics appliances, we have now integrated our prosthetics purchasing authority with FAR and VA acquisition regulation provisions. In this integration, the 8123 is primarily employed as a statutory basis for a FAR Part 6 justification. This is for other than full and open competition. What this means in practice is that if a clinician who has been trained on a particular product has felt comfortable with that product, then they can be assured that a government procurement official will not restrict them from selecting and using a product with which they feel competent for their patients. This application of our prosthetics authority enables clinicians to make choices based on their medical determination of what is best for our patients. In complicated systems, it is always possible to improve our management and tracking controls. We have made significant progress, often setting industry standards in tracking medications, blood products, and implants. However, we do acknowledge we can improve our tracking and inventory management of biological implantables, including tissue. In 2013, the Federal Food and Drug Administration published a final rule requiring most medical devices distributed in the U.S. carry a unique device identifier, or UDI, and that information concerning each covered device be submitted to the Global Unique Identification Database. The rule does contain a staggered compliance date. With the advent of this new identifier, systems should be able to track a specific item and associated with the manufacturer. This will improve adverse event tracking and will further enable greater automation in product recalls. However, I do need to be clear. This rule does not yet apply to biological and tissue implants. VHA will be participating with the FDA this summer in the formulation of this policy and applying to biologics and tissue implants. With the more recent developments in the biological implants industry and in reaction to external audits and reviews, as well as this committee's oversight, VHA has established a work team to identify improvements to our sourcing, management, and control of biologics. This work team is expected to complete its review and recommendations in the third quarter of fiscal 2014. We will review their product and then begin the process of establishing a standard protocol across each of our medical centers. Similarly, we have charged a work team to develop a set of new national contracts for biological implants. This work team is in the phase of procurement that we call the development of requirements. The team is comprised of clinician leaders as well as logistics and prosthetics specialists. We expect our procurement packages to establish stringent quality standards not available on previous federal supply schedule contracts. My personal performance contract contains the expectation that this solicitation phase for this new procurement action will be initiated prior to the end of fiscal 14. In conclusion, our mission in VHA is the delivery of timely, quality, patient-centered care. Our systems must apply controls where appropriate to further this mission. We acknowledge we must seek, define, and implement improvements to our management, tracking, and control of biologics items. We are committed to making necessary changes to our policies, practices, and systems to improve. We must, however, ensure our procurement system achieves and complies with all federal laws and regulations, but that it also achieves a balance. It must enable our physicians, whom we trust with the most critical decisions, to apply clinical discretion when needed to provide veterans with individualized health care. Mr. Chairman, this concludes my testimony. I appreciate this committee's continued interest in and care of the health and welfare of America's veterans. At this time, my colleagues and I are prepared to answer your questions, sir.
And thank you for your testimony. Dr. Matowski, there are at least 10 VA doctors on the board of directors for the Musculoskeletal Transplant Foundation, of which VA has purchased over $1 million in biological implants over the past 15 months. Is this relationship a conflict of interest?
Mr. Chairman, thank you for your question. All of our employees are required to declare by our ethics policy any conflicts of interest. As a matter of fact, in each of our clinical committee meetings, they are required to announce any conflicts of interest. We researched some of these assertions. We went back and identified each of the clinicians, and we did not find in our review any involvement in the procurement decisions associated with the MTF organization. I would add that Musculoskeletal Transplant Foundation is a nonprofit organization, which I do believe is an AATB accredited tissue bank.
Thank you. I think that the entity you just referred to did $4 billion of business last year. The criminal conflict of interest statute in 18 United States Code Section 208 prohibits a federal employee from participating personally and substantially in a particular official duty that will have a direct and predictable effect on the employee's own financial interests. Do the VA clinicians who sit on the board of biological implant vendors violate this statute?
I do not believe they did, sir. They are required by policy to notify their management of any conflict of interest, any boards they may sit on. And if they are involved in a procurement decision that may be associated with a firm with which they might be associated externally, they are to recuse themselves from that transaction. We did not find an instance where they were involved in that procurement decision.
Mr. Matowski, according to your memo dated May 23rd, 2012, surgical implants are required to be bought on the FSS or Federal Supply Schedule unless a waiver is obtained from the director of the National Acquisition Center. Is a waiver obtained from the director for every surgical implant purchased on the open market?
In many cases, the biological implants that are acquired are below the micro-purchase threshold. Since those are not going to be affected by a procurement organization or a contracting officer, many of those do not have a waiver. I will point out that in, I believe it's fiscal 13, there were 21 waivers. That may not sound like a large number, but that's a waiver for a contract that would be a local contract that would cover many purchases. We have actually requested that our contracting officers increase their scrutiny to ensure that anything that we're acquiring that doesn't conform to the VAR, this is the VAR hierarchy, that we have waivers for that. We're able to monitor that now much better in the procurement organization.
Is it something like, my understanding is something like 97% of the purchases are micro purchases?
Something I think in the biologics area, it's about 95%.
Thank you. It just seems to me that there's an intentional effort to negate the rule by virtue of doing the smaller purchases.
Well, I don't know with all due respect, sir, I don't know that that's necessarily the case. In many cases, these are acquired in time for a surgical procedure. So a surgeon may be going into a procedure and will acquire that item. A dermal graft may be a micro purchase, but in some cases, some of our dermal grafts have to be stored at negative 43 degrees Fahrenheit, and the storage requirement for that would negate us having it around for quite a while. So you'll acquire it in time for the procedure, and we're not keeping a significant stock of these items. So you'll see smaller purchase items. Having said that, I want to be clear, we do want to have a clinically cleared national contract available for us that includes certification and accreditation, and then promulgate that contract for broad use.
Mr. Waltz.
Thank you, Mr. Chairman. In your testimony, sir, it said VA is developing the implant tracking in VH cardiology and surgery and wants a single comprehensive tracking system. What's the time frame on getting to that single comprehensive tracking system?
Some of that will depend, Congressman Walz, on our analysis. We have a group that is meeting face-to-face next week. We do expect their recommendations in the third quarter. Some of what we're going to have to do is going to require an interface to VISTA, CPRS. Those interfaces to VISTA will have to be an IT-funded requirement. As we went through our IT requirements exercise for FY15, implant tracking and alerting was one of our higher priority items to get funded. But there will be some requirement on IT funding to be able to deliver the completed system. I will tell you that as we looked across what we're doing in some of our networks today, there are commercial systems that are barcode-enabled systems that would allow us to better track, both in the OR setting and in the outpatient setting. That may be possible. It may be possible for us to acquire that with medical resources, which might expedite that portion of it. The connection to VISTA, though, would require an IT fix.
Well, I'm probably not telling you anything new, but coming here with IT funding request is going to be met. I'm not sure I'll let my colleagues use the words they'll use on that, but this is a difficult one because of the roads we've been down. So I ask you to make sure that we've evaluated that thoroughly, because more requests for more IT when we still don't have seamless transition between DoD, that's a tough sell. I hear what you're saying, though. Other than the part played by the National Center for Patient Safety, VA's taken a somewhat decentralized approach to tracking. My question to you is, and I started to research this, I represent the district that has the Mayo Clinic. How would an organization like that do this, as opposed to the VA? If you can give me your insights on how that works, if you know.
Well, I'm going to defer to some of my colleagues here. And in response, we'll answer two questions. I think one of them is our recall process, and then the question might be, our tracking in blood and the extension of the blood tracking that we do today. We've frankly been doing that for decades down to the patient level, and I'll ask Dr. Accardi to weigh in. We have a three-step process for recalls. The first question is, do we have this item in our inventory? Is it something we have acquired? And on a recall, the first action is to pull from inventory. Then there's a clinical decision to determine whether or not there's clinical significance for a patient directly. And then lastly, the patient involvement and close out with the patient, which may involve tracking, it may involve removal of an implant, for instance, a hip. But I'm going to ask Dr. Accardi to walk us through a little bit of what we've done in the blood bank since 2006.
Well, since 2006, sorry about that. Since 2006, we have had the VBEX system up, which allows us to go through and track all of our blood products, and combined with what the FDA and CDC does, that allows you to track a blood product from when it is initially collected all the way until its final disposal.
And that's how a large private sector would do the same way?
Yes.
Best practice that way?
Yes.
Okay. Okay. The next one I have, and this one I'm still trying to wrap my mind around. In the GAO report, it states that there's a possibility that VAs utilize tissue implants from vendors that have not registered with the FDA. My question is twofold again. How does that happening? How does it happen? And do you believe that's happening outside the VA also? Is this a system-wide problem in healthcare delivery? Because this one seems pretty staggering to me that would be allowed to happen. So please.
Quite frankly, I'm not quite sure the nature of that finding. I think that the nature of that finding would be that in review of the recorded purchasing transactions, that some of them, they would indicate that the record keeping might indicate that it's not an FDA. I don't have any indication to confirm that, quite frankly. Do I think it's a broader issue across the healthcare industry? I can't opine.
So what you're saying is they may have been, or they should have been registered, we just don't have the paperwork to prove that they were registered with?
No, I think it's just a matter of record keeping, ensuring that what we have in our national prosthetics patient database is the valid recording, and if it contains information that may be subject to human error, then there's some question as to whether or not that would be
Does it concern
audited.
you that that might be the case?
Well, I think we want to have a standard national contract that we know has clinical input into it, quite frankly. So yes.
Okay. With that, I yield back. Thank you, Mr. Chairman.
Dr. Rowe?
Thank you all for being here today, and let me just go over a few things. And first of all, I've used biologics, and as I've looked into this, and obviously they have been tremendous for patients. There's no question about that. I think one of the concerns we had, and certainly in my state of Tennessee, was when we had an outbreak of some contaminated epidurals medication that caused some people to die. It was contaminated with a fungus, and we were able to trace that right back to its source, stop that, not use that source. The way I understand this from the GAO report, the part that I've read, is that when you buy, some of the vendors that you bought from have not been FDA approved. Is that correct?
I think that's in their report, I believe. Yes, sir.
That's not what I asked. I said, is it correct?
I don't know that it's correct, sir.
Okay. So you don't know for sure that it is or isn't. Okay.
Correct.
Fair enough. And when these are placed, do you tell the patients that they're getting a biologic? Do they understand? And let me explain where I'm coming from, because the patients expect us, the system, to make sure what goes in them is safe. They expect us to have done our due diligence. And if you look at tissue, allograft tissue, it can come from foreign sources. And some of those sources, and I've done a little bit of research on that, one story from Ukraine, and there have been of tissue that was contaminated, and what patients don't understand is this has to be retrieved under certain conditions. And there have to be people who are excluded who have cancer, who have any infectious disease. Certainly the case that the chairman brought up with rabies obviously should never have been, that's a different system, a tracking system, organ transplantation as opposed to allograft transplantation. But patients have that right. And if that happened, if a patient was contaminated by, let's say, hepatitis C, hepatitis B, does the VA have a system that could track those patients down?
We do. It's important to note as we
Well, you're saying to me now that even though some hospitals don't have a system that's tracking, that the VA could track that from its source of origin to that individual patient. You all have that system in place. That's good if you do.
I will walk through the scenarios that we have that I can state definitively, Congressman Rowe. Since roughly 2008, there have been 13 recalls for biologics that the VA has, that have been triggered a National Center for Patient Safety action within the VA. 6 of those we had in our inventory. I'm going to ask Dr. Gunnar to walk us through a little bit about that recall process, but it's important to note that in 6 of those that we had in one of our medical centers some inventory. There's then a clinical determination as to whether or not we need to notify the patient. And I'm going to ask Dr. Gunnar to elaborate on that. But in those recall instances, we've been able to track inventory, facility, and then take clinical action.
Just a commentary before he does. I would absolutely think you ought to notify the patients. I mean, that's the most affected person. And I think out there now, if I'm a patient that got a new anterior cruciate ligament, and I found out later that the source was contaminated, I think it would at least be fair to tell that person so they could be tested. And we've been down this road before with contaminated colonoscopes and other things. This is not new.
In a couple of these cases, the recall itself was rescinded.
I can assure you, Congressman Rowe, that in those situations we would, there's policy, VHA policy regarding disclosure of adverse events, And we would, National Center of Patient Safety would work with the program offices as well as the facilities and the providers to identify the individuals who received that implant and make sure that the correct clinical action occurs.
But there is what I'm hearing from you all is that there is a system to do that now. So
Correct. There's a system in place to do that now. What we don't have is that single button. And I think that's what what the bill supposes, that we would have a
Plug the hole.
barcoding system that we'd be able to go to one source and push the button and the list would come up.
Well,
And unfortunately, we don't have that source.
okay, there's another issue that doesn't affect the VA, but the FDA, and that is, and this is a little bothersome, this is not anything to do with you all at all, but when they approve a tissue bank, sometimes they don't go back for years to ever examine that tissue bank, and that's a little worrisome because the patients expect us, and the surgeon who uses material that he or she is used to using, I get that. I mean, we got our little toys we like to use, but we expect that particular piece of tissue that we get is safe when we get it. I mean, we're assuming that the people who procure that for us have done the due diligence to make sure that when we do transplant that into a patient, that patient's getting a safe graft. And I guess the other thing I'll ask, Dr. Gunner, does the staff inform patients that they're getting an allograft? I know I always did, but it's not required, I don't think.
It's actually by policy required in our timeout process. So the implant is actually, you have to, before the procedure even starts, you have to assure that the implant is there, that it's not.
No, that's not what I mean. I mean, does the patient know they're getting an allograft?
Yes, in the informed consent process.
And the last question, and I'm sorry I ran over just a second here, but the other one is how do you, for expired tissue, and that's obviously very important, that the GAO found still sitting on the shelves, why did that happen?
Well, I believe that was some time ago, and Mr. Matkovsky can comment about how the inventory was managed following that. But what I can tell you is that there has now been the policy that it ensures correct surgery and invasive procedures requires that there be a readback of the expiration date on any biologic that's going to be implanted.
Well, do you think any expired tissue's been implanted into anybody?
I'm sorry,
Tissue expired.
Yes.
Got to the operating room, got implanted into a patient. Has that happened?
To my knowledge, that's not happened, but I think there is a culture of safety that's developed in the VA that is associated with a national policy that would provide assurances that would not occur.
Well, it could if that tissue was still sitting there on the shelf. Anyway, I yield back.
Mr. Carnes, I would simply indicate, though, I mean, I think the discussion of the tracking and alerting mechanism, we do need that. We do need a mechanism to better manage the inventory in facility. I would concur.
Mr. Huelskamp?
Thank you, Mr. Chairman. Appreciate the chance to discuss this issue today. First thing I want to turn to with Mr. Matkovsky, the National Center for Patient Safety, that's internal to the VA, is that correct?
That is correct, sir.
And as I read and review the GAO report, they presume that all the recall notices and such coming out of that NCPS are sufficient and conclusive of what needs to be recalled. Is that your understanding?
We believe so, yes, sir.
How different is that from other systems that impact this particular industry, and how is it different than what's in the industry? Again, this is only internal to the VA, and the GAO assumes every recall that was necessary was identified by NCPS.
I think NCPS is actually an aggressive organization inside. I think it has a very forward-leaning stance. It works with programs. I think our scale is different than other entities in the private sector. But other than that, I think it functions in much the same way as a recall entity would in the private sector. But it's really a very strong coordinative entity that can trigger a recall either from an internal source or from an external source works with the program office, be it surgery or blood, pulls data where we can at a national level, and then can issue a recall notice down to the facility and follow it through to its completion.
Does this work together with the FDA?
If the FDA issues a recall, yes, sir, it would. So it would trigger an FDA recall, would trigger a patient safety alert for us.
Now, you do work with non-FDA vendors. How do you work with those if, again, they're not registered with the FDA, they're not approved by the FDA, but you're using their products?
If there's a recall action, we would be notified, and then we would initiate the recall action for that item. I'm sorry, I'm not sure I understand. Sorry.
I don't understand why you're working with non-FDA vendors. Could you describe why you're working with non-FDA vendors in this particular arena?
I don't know that we are working with non-FDA vendors, sir.
Didn't the GAO report identify?
I think
that?
they indicated that given record-keeping issues that we
You
could
have
not-
no idea if you're working with non-FDA vendors, is that correct?
I do not believe that's correct, sir.
Okay, you said you do not have the paperwork to determine that you always work with FDA vendors.
No, I think the GAO comment was that we could not assure, given our record system, that we were...
Can you assure me today you are not working with any non-FDA vendor?
I can take that for the record and research everyone.
Yes or no?
I will take it for the record, sir.
Yeah, so you cannot assure us today you're not working with non-FDA vendors. That's the GAO report. That's what they're saying. You do not have the paperwork to identify that. I'm just trying to get the basis of that. So you're taking that system, which you do not have the paperwork for, that's also the basis for which the GAO indicates you're following your own internal standards for recall. Are there recalls that take place elsewhere in this country that the NCPS did not feel proper to have a recall within the
In many cases, we'll have a recall that's not triggered by the FDA. Our own internal organization may trigger more recalls than would be triggered outside.
My question is there a recall that elsewhere in this particular industry that the NCPS chose not to precipitate within the VA system?
I do not know of any.
Could you provide any proof of that for later reference? I would appreciate knowing that.
And I would also go back and I'll research the data down to the granular data to look at every vendor we've purchased from.
Okay, well, I appreciate that, because to me that's core from the GAO report, because there is not the data there to answer the question, to say, hey, yes, we are only working. Is there a reason you would work with a non-FDA vendor?
There is none, sir.
There is none whatsoever.
I think the other thing that's also getting lost in some of this, the GAO is performing an audit function against the data we can provide. It is a time-limited audit. We're going off the data we can provide. There is an accreditation function that occurs in each one of our facilities. Each of our facilities is a Joint Commission accredited entity that has its own processes reviewed by the Commission.
And I understand that, but you're using the VA's National Center for Patient Safety as the basis for making these decisions. That's all internal to the VA. My concern is an external source on that. Lastly, you made some reference in your oral testimony, it's not in your written testimony, about personal performance contract. Could you describe that a little further?
I will, sir. Following our hearing on January 15th, I went back and modified my performance contract and added in there that we would have a clinically cleared national biologics contract by the end of, the requirement set by the end of this fiscal year. So it would go into the solicitation process. So I've modified my performance contract to be personally accountable.
Okay.
I think it's important.
You modify your own contract with the federal government?
It is, we all have a performance agreement. So I inserted into my performance agreement, working with my boss at the time. She and I had a discussion when I came back from this hearing, and I thought that I needed to ensure that I was personally accountable to make sure we did this.
Can we receive a copy of that personal
You certainly may,
performance?
sir.
That's the first time I've heard about that, and the first time I've heard of anybody say they altered their own personal performance contract. So did you get a bonus last year, and that's or not?
I think mine is still in deliberation, sir. I think it's a performance award, and I think it's still in deliberation.
Is it based on your old written contract, or is it based on your new one you rewrote?
My new one will take effect for the period of fiscal 14. At the conclusion of fiscal 14, if I'm unable to actually deliver a requirements package for biologics, it will affect my personal performance, yes.
So you don't know if you got a bonus for fiscal year 13 from 6 months ago?
I do not, sir.
When will they tell you as an employee?
I don't know.
Who makes that decision?
I also don't know. I'm not sure I want
So
to.
you have a contract with a Superior, you don't know who makes the determination on the bonus?
Things
and
happen.
Actually, they don't happen.
Well,
Sir, I have a hard time believing you don't know Who's making the decision on whether you get a bonus or not?
I believe the secretary makes a decision
Okay.
finally and reviews it.
So the secretary makes the decision. He's waited 6 months and hasn't told you yet. So that's correct?
That is correct.
Thank you. I yield back.
Dr. Benishek?
Thank you, Mr. Chairman. I thank you all for being here this morning. Dr. Gunner, are you involved in the process of fixing this? I mean, Mr. Matkowski said how they don't quite have the plan yet for, or don't have an accurate method of tracking all this stuff right to the patient, I guess at the macro level, really, because I think in each hospital, they sort of track it. But are you involved in that process? I mean, it looks like you're the director of surgery for the VA. So I always like to have the doctor involved with, a lot of this stuff. So I just want to know if you're involved in that.
So I'm involved in the surgical world, and was instrumental in modifying the Vista surgery package back in 2011 to actually add implant information at the time in the OR. The Vista surgery package is not used for out of operating room procedures. And the majority of biologics, to take it back to the subject of this hearing, are actually applied in the outpatient arena. I think that for that reason, we've testified that conceptually we want to align this with the blood bank concept of barcoding and be able to.
So you think that Dr. Accardi, then, would you have more?
Correct. I think in the world of biologics.
So you haven't really been involved in that process.
But I am involved.
Yeah.
Yes, absolutely.
Well, it sounds like you said that you were involved in the stuff that went to the OR, but not involved in the stuff that didn't get to the OR. Is that correct? It's more like a blood banking issue, and then the blood banking people are more in charge of that sort of thing. Then is that what you're saying?
Congressman, this is, and I appreciate the question. This is the work group that is established that will come to a decision in the third quarter of this year.
Well, the point I'm trying to get at, Dr. Gunner, is that I get very uncomfortable. I'm a general surgeon too, and I get uncomfortable when people who aren't physicians are making decisions that affect patients. I like to see the doctors, because I think as physicians, our primary concern is for the patient. At least mine always was. And now you have a whole team working behind you when you're in the operating room, and you want to be sure that they're all doing their job. And I understand that you can't oversee that piece of material from the beginning to the end yourself. And I like to see that physicians are at least in charge of the process or involved in the discussion. So.
Dr. Accardi, to answer your question specifically, Dr. Accardi and I and other clinicians, program offices within central office are engaged in this work group and are participating as leaders as this work group moves forward.
Well, Dr. Accardi, let me ask you then, what input have you provided for this process of making sure that the VA has an accurate identification process for biologics?
Well, as you know, biologics, they break into the two sides. There's the blood side, and then there's the tissue side under thing. And so in the blood bank, we handle mainly blood. Well, and so where we have been involved.
Okay, well, it sounds as if you're kind of backing away from the tissue side, and you're talking about just blood. So if it's not Dr. Gunner and it's not you with the tissue, then where is the doctor who follows the tissue?
Be very clear here. Both of these gentlemen to my left and my right are involved in this team. This will be a clinically led team. The recommendation will be informed by our clinicians. Our ultimate decision is to the process owner.
Well, no, I understand that. It's just
Right.
that
So
when Dr. Accardi answered me, and then it's kind of was backing away from the tissue issue. I'm trying to find out, who is the doctor involved in planning for the tissue? And And apparently, am I incorrect? Are you involved in planning for the tissue, how that all works? But you sound like you said, no, I'm involved with the blood.
Nationally, we're involved with the blood. On the local level, there are some blood banks which are involved with tissue. And as J.O. noted, it does vary from facility to facility.
So who is the doctor that's leading the charge on making sure the tissue is well cared for from beginning to implantation?
Well, Dr. Gunner has.
Well,
Okay, all right. Well, I guess my time is up, but I appreciate what we heard here this morning. Thanks.
if I may, just one clarification for Dr. Benishak. Thank you. Surgery is involved in this process definition. We have gone out, we have canvassed, we've surveyed all of our medical centers. We've looked at what practices we have, and some of our practices have the local blood bank actually managing the tissue. We have a really strong practice that has been in place for decades. We have established processes, established clinical directives with clinical leadership. Our expectation is...
I understand you're saying all that,
Right.
Mr. Matkowski, but you brought two physicians here with you. I asked each of them how are you involved in the process? And Dr. Gunner said, well, I'm in the OR. He limited his answer immediately. And then so did Dr. Accardi limit his answer immediately. So I'm wondering who is the person then who is the physician who's directing, the processing of tissue? And it's not either one of these. Is there someone else? You know what I mean? So that's the problem that I have with what happened here this morning.
Okay.
We'll go into the second round of questions. One question I have, the GAO report discuss the death of a veteran? So it says, according to a report, I'm sorry, this is in the Journal of the American Medical Association, the kidneys of an Air Force recruit from North Carolina who died from a rabies infection in July 2013 were transplanted into a Maryland veteran who later died from complications with rabies. Are you acknowledging or denying that that event occurred? Okay. Okay. I understand that might have occurred at Walter Reed, so.
I
Okay.
comment on
Let me go into why has the Veterans Implant Tracking System, a vital tool necessary for patient safety, been allowed to stall?
I don't know that it was allowed to stall, Mr. Chairman. I think it finished software development, then it went into testing. I believe Dr. Gunner at the end of FY13 went into testing, and some critical defects were identified. And then I believe that it sort of got caught up in the IT funding question.
According to GAO's testimony, VHA has no oversight ensuring VAMCs check their inventory for and alert affected patients for recall products. Why is no oversight conducted to ensure this safety measure is carried out?
You know, from 2008 to 2000 and end of 2013, there were 13 recalls that were triggered and notified to the VA. Of those, 6 of them were identified as having an effect on our inventory. So, the statement that we have no mechanism, I don't know that that's entirely accurate, because we are able to identify in those 6 cases for those recalls that we had inventory supply or had inventory supply at some time and initiated a local recall process. It is correct, however, I want to be clear, that managing the inventory and having greater granular control can be improved with a better tracking system.
According to GAO, VA does not ensure that biological implant vendors are registered with the FDA. Isn't a simple verification important for patient safety?
Yes, in so many words, it is.
Very well. Mr. Waltz?
No further questions.
No further questions. Dr. Rowe? No further questions. Mr. Huelskamp? No further questions. Very well. Thank you very much, panel, for your testimony. On our second panel, we will hear from Ms. Marcia Cross, Director of Healthcare for the Government Accountability Office. Your complete written statement will be made part of the hearing record. Ms. Cross, you are now recognized for 5 minutes.
Thank you. The committee. I'm pleased to be here to discuss our work on the safety of tissue products used at the Veterans Health Administration. In fiscal year 2013, approximately 59,000 tissue products were used to provide care to veterans at VA medical centers. The tissue products most commonly used by VHA are bone and skin grafts. While tissue products may improve quality carry the transmitting a communicable disease from a donor to a recipient, potentially resulting in complications. The Food and Drug Administration, FDA, is responsible for regulating the manufacture of tissue products. These products are generally regulated under FDA's human tissue regulations or under FDA's medical device regulations. Establishments that manufacture tissue products must register annually with FDA and must follow applicable regulations, including reporting certain adverse events and following current good manufacturing practices. Although VA relies on FDA to ensure the quality of its tissue vendors, VA policies do not require that a vendor's FDA registration status, an important component of federal oversight, be checked for most purchases. VHA officials told us that for open market purchases, the agency does not require purchasing staff and contracting officers to check the FDA registration status of tissue product vendors. Open market purchases account for 57% of the tissue products that are procured, with purchases made from several hundred different vendors. For the remaining purchases made under fewer than a dozen federal supply schedule contracts, VA does check vendors' registration status for tissue products regulated as medical devices. However, there is no policy requiring staff to check a vendor's registration status for products regulated under FDA's human tissue regulations. It's important to note that VHA has not found evidence that it has received contaminated tissue products. It is often not possible to definitively attribute post-surgical infections to a tissue product, and it is not uncommon for such infections to occur, even in the absence of tissue use. In the past 5 years, VA has notified its medical centers of 13 recalls for tissue products, and these recalls were generally issued because of the possibility of contamination, not because of known contamination. When a recall does occur, VHA's ability to identify and track recalled tissue products in its inventories may be limited by poor inventory management practices. The medical centers are required to search their inventories for any recalled products that have not been used. But GAO and the VA OIG have previously reported concerns with the completeness and accuracy of VHA's inventory data and have made recommendations for improvement. Further, while VA medical centers are also responsible for accurately identifying all recalled tissue products that have been used, identifying implanted tissues may be a challenging task for the medical centers to accomplish. Officials stated that it is difficult to search for information on tissue products that have been implanted in the operating room, in part because there is no automated search capability. We also found that VHA conducts no oversight to ensure that these checks of patient records are performed. VA is taking steps that may improve its ability to track tissue products. For example, VA officials told us that the agency is continuing development of the Veterans Implant Tracking and Alert System, VITAS, which was created to track and retrieve identifying information on surgical implants, including tissue products. In addition, the agency told us that it established a working group to determine the feasibility of utilizing scanning and tracking technology to automatically upload tissue product information into patients' medical records. In summary, VA's recent actions may improve VHA's ability to identify tissue products both in inventories and used to treat veterans. Mr. Chairman, this completes my prepared statement. I'd be happy to respond to any questions that you or members of the subcommittee may have.
Thank you, Ms. Marsha Cross. I've got a few questions. Some tissue products have already been implanted, injected, or applied by the time a recall occurs. How does VHA ensure that veterans who have been the recipient of such products are identified and notified?
Well, they've told us that it's very difficult for them to identify the patients who've received those products. For the tissue products that are implanted in an operating room, they are required to enter information, identifying information about the source and lot number and such of that product into the patient's record, but it's manually entered, and it is not searchable except by pulling up a text field and so someone must actually go through each patient record to determine if they had a relevant product implanted. For the outpatient clinics, it's even less clear how the information could be tracked.
Are the steps VA medical centers take to notify patients of a product recall sufficient to enable prompt identification?
It's not clear. As I said, it's not clear that contaminated tissues have actually been implanted into patients in VA medical facilities. There's been a small number of recalls. I'd like to clarify that among those 13 recalls, 6 of them, they identified product at 27 different facilities. The remaining 7 were sent out because there was a belief that the VA had purchased these products. They did not find any. Whether that meant they had already been used or had expired, we don't know. The steps to actually identify patients, I'm not aware that there have been any notifications given to patients that they've received a contaminated tissue. VA has told us they're not aware of any cases of such contamination occurring.
Ms. Cross, what is the problem with VA medical centers operating room staff entering implant serial and model numbers into medical records by hand?
Well, you have the potential for error, just simple transcription error of someone's having to type something in. And in addition, it's not entered into something that's automatically searchable. It's in a field where you actually have to go back then and read it and compare it to the product that you'd be looking for. It's not something that's it's not like a barcode that's automatically read into the record.
Okay, thank you very much. Mr. Walz?
Well, thank you, Mr. Chairman. Thanks, Ms. Cross. Is VA's purchasing and tracking of biological implants the same as private industry?
We haven't looked at what private industry does. Some of the same problems exist. There's a new system that's coming online for those tissue products that are regulated as medical devices, the unique device identifier system that is going to be used by facilities throughout the country, VA or private. There isn't a similar system in place for identification for biologics that are regulated as tissue products. And so I think each individual facility has been and will continue to be making its own decisions about what kind of system they have to track.
Maybe Mr. Wilton can help me with that. The reason I keep bringing this up, and I think one of my colleagues mentioned it, we need these facilities to be the best. When my folks at the Mayo Clinic tell me that the cardiology at Mayo Minneapolis is the best in the world, that's a good thing. That's the way it should be. I keep bringing this back up because it's important holistically as we approach medical reform to understand what the private sector is doing, where they're doing it better, where they're doing it less. And I understand this committee's scope of responsibility is the VA, and we're exercising that. I bring this in to see if we can learn from each other. I know we do that often, and it seems like this would be one of those issues where that would be pertinent information. So we're not operating in a vacuum. My next one is, how will you, and maybe it's not you, maybe it's in conjunction with the IG to follow up on your report, How will you follow up regarding the recommendations you made in the 2014 report here?
GAO does follow up routinely. We follow up at least annually with the agency to determine what actions have been taken to make changes in accordance with the recommendations that we've made. And we publish an annual report giving the status of recommendations that's available on the GAO's website. And we track recommendations for at least 5 years.
Will our veterans be safer if they follow your recommendations?
We believe that those recommendations are grounded in, the need for actual changes to occur, that it will improve the care that's given to veterans if these changes are made in their inventory management practices.
And I, for one, I do appreciate it, and I think Mr. Holzkamp was hitting on something important, and I was curious, too, about his questions on how this worked. I do think it's admirable that there is going to be a connection to whether these things are followed through with, whether this report is implemented, to someone that we can address. So I want to highlight that, though, but he did bring up an interesting point, is who's going to make that ultimate decision. That would be an important thing. Now, you said the secretary, but I do like this, that all of us in conjunction here, because the ultimate goal is accountability for veteran safety. And so now your report, and they're working with it, and they're adding back, and if the private sector can add anything, which we'll hear on our next panel, that's our goal. So I'm appreciative of that. With that, I'll yield back the remainder of my time.
Thank you, Mr. Waltz. And just a very quick point, I think that in the private entities, as you mentioned, Mr. Waltz, I think that families, if there's a lapse in patient safety, have recourse through the court system where our veterans rely on us. Dr. Rowe?
Thank you. And just to dovetail on what Mr. Waltz was saying, I really appreciated Mr. Makovsky. That's the first time since I've been here in 5.5 years that somebody said the buck stops here. And I appreciate that. And the fact that you're going to put yourself at some financial risk if you don't get this done by the criteria done and so forth, not completely implemented. I understand that by the end of the year. So thank you for that. Ms. Cross, a couple of things that just looking here, and the more I delve into this, the more I realize it's not just the VA. This is a system-wide. Perhaps we'll hear from our third panel what's going on in the private sector, but it's a little disconcerting that the FDA would approve a tissue bank and then not go back and look at it for several years to see if they're up to standard or doing what they're supposed to. I think that's something that started my wheels turning a little bit, that your report pointed out to me a deficiency not just in VA. They can't help what the FDA does. So maybe we need to take another step toward that direction. Would you agree with that?
Well, the FDA has a risk-based system that they use for tissue products. They also have a risk-based system that they use for making determinations about inspecting medical device establishments and drug manufacturers. The data that they provided to us indicated that they'd inspected about a quarter of the tissue banking facilities that were registered with them in the last fiscal year. About 600 inspections had been done out of about 2,500 or 2,600 registered establishments. That actually is in line with or perhaps somewhat higher than the inspections they're performing for medical device establishments and for drug manufacturers. We previously put out a series of reports, and FDA has begun to shift their inspections because they were generally inspecting drug manufacturers domestically and not abroad. And so they have been shifting where they're targeting their inspections and trying to target on those that are manufacturing the riskiest products. I can't speak to whether it's an appropriate frequency, but that's the frequency they have with the resources they have.
I think the thing that when you see FDA approved, I mean, they have a great reputation, the FDA does, looking after safety. And quite frankly, what we've heard today is that so that our viewers out there understand that for the most part, this is very, very safe and very beneficial. But there are holes in there that we need to plug up and make sure, because if you're a patient, one patient, I mean, that young veteran who, or I guess active duty, who got a kidney transplant, that was 100% for him, that he got rabies and died because of that mistake that was made. So as a physician, we've got to be right every time. And the folks that are providing, or as every time as we can, and the systems that are providing this material for us, they have to be right on nearly 100% perfect. And obviously errors can be made, but 57%, 341 different vendors the VA used that made these small purchases that weren't, as I understand it, we didn't check the FDA. An open source, as I heard you say, they didn't check the FDA status. So that means a lot of those never got checked. We just made an assumption it was safe.
We don't know if they check.
You don't know, okay.
And I think that's a concern. There's no policy that requires that a check be made. Unlike the federal supply schedule purchases, where actually part of that process requires that they check the FDA registration status for establishments making products that are regulated as medical devices. There is nothing for the small market, the small purchases that are made, the open market purchases. And similarly, even for the federal supply schedule purchases, there's no required check in place to ascertain the registration status for the products that are regulated as tissues as opposed to those regulated as devices.
Now, I think the other thing is just because something is FDA approved doesn't mean it's 100% safe, and because it hadn't been doesn't mean it isn't either. I think that's because of the clinical outcomes of most of these 59,000 people, and they've had no reported cases, I guess, unless the tracking is that poor.
There have been adverse events reported to FDA. When FDA has conducted investigations, they have positively confirmed 2 donors from whom contaminated tissues were recovered and that were sent out to facilities, but neither of those instances involved VHA facilities. For the confirmed cases. There are recalls, adverse events are required to be reported to FDA, and there are instances in which there's at least the possibility of contamination that they want to have those products recovered from inventory and patients checked. We know that there's a process for recovering from inventory. We're not sure what's happening in terms of checking patient records.
No, just as I finish, Mr. Chairman, you know, it looks like that, as you pointed out, and human error and the barcode, that technology is available. So, I mean, Harris Teeter knows when I walk in and buy a box of cereal what I bought. And they send me a coupon 3 weeks later for 50 cents off. So it should be fairly easy to do that. That's not new technology. It's been around forever. And it would create a line downstream to find out where this came from, where the source was, and you could track it much easier. I think that would simplify it tremendously. I yield back.
Mr. Huelskamp?
Thank you, Mr. Chairman. Ms. Cross, the question for Mr. Waltz was about what is happening in the private sector, how this occurs, and you didn't have experience on that, hadn't compared that. Are you able to compare that to other sectors of the federal government? The DOD is an enormous system. Do they use non-FDA approved items? Do they purchase off the schedule? Can you shed any light on the comparison there?
I'm afraid our review did not focus on what was happening in other federal healthcare facilities. We only were looking at what was happening at the VA.
Okay, but you did, and I appreciate that. I understand the limits on that. You did look at the VA's OIG study in March of 2012, where
Yes.
it indicated that informal tracking systems, I'm not sure how well informal tracking systems work, and if you're trying to look at a recall, if you're trying to look at adverse effects, they can't even track the product on the shelves, much less the patients. And so if I ask the question, as you saw earlier, it's, well, we don't know. We actually don't know what we don't know. Is that an accurate assessment of an informal tracking system that no one knows for sure what is there? It's just a best guess.
Different facilities, according to the IG's report, different facilities had their own individual systems in place for tracking. There was not a centralized system. It could not be accessed by VHA systems. But as I understand it, that's part of the changes that have been being put in place that Dr. Gunner spoke to, specifically for those products that are implanted in operating rooms. I'm not sure what's being done for the outpatient facilities.
And you reviewed the report. Do you know if this has been implemented, how far along they are on fixing this informal tracking system, which is the basis for saying that no adverse events have been reported on the use of these tissues?
Our understanding is that the comprehensive inventory management system is part of what was discussed earlier, and that the last update we had was that it was supposed to begin to come online in 2015.
Okay, so it's still not there. So one of the questions I did ask of the VA, like follow up on, is the populating the NCPS system, or NCPS is, in your opinion, is that sufficient? Can you describe for the committee how it's determined that you do a recall? Again, I presume, actually, if the FDA had a recall, that didn't mean that VA actually initiated a recall either. They weren't always the same. Can you describe that a little bit more about the internal VA system that everything's hinging on in terms of this report?
Well, the NCPS system is used to try to track recall products that may still be in inventory. And so there is that centralized system that allows them to go out, that covers the VAMCs, and that would allow them to determine whether or not those products had been procured at different facilities, so that they could then have the facility go and remove that product from the shelf. There have been some concerns about the accuracy of all the information that's in that system, but nevertheless, that at least provides a centralized source. The gap, I think, occurs because VHA doesn't have oversight of what's happened for the tissues that have been used that may be covered by that recall, and that's where the VAMCs are individually responsible for checking individual patient records to make a determination of whether or not someone received an implanted product that had been recalled and whether notification to that patient is warranted.
And you do also note that although the NCPS tracks and responds to recalls, at least partially, I would say, they do not track warning letters. Can you describe that a little bit more, why those are ignored by the system?
Well, VA told us that the information in warning letters is really not that helpful for them, because the warning letters that FDA puts out are really focused on changes that a company needs to make in order to be in compliance with FDA requirements, and would not necessarily result in products having been distributed that were contaminated or otherwise needed to be subject to a recall. And there have only been a small number of warning letters to tissue establishments in the last several years, but the VA indicated they didn't believe that would provide them with actionable information.
Mm-hmm. Even though in one case the FDA issued a warning letter to a vendor, and the VHA did not know about that, and obviously didn't respond to that because they only respond to partially to recalls. Ms. Cross, I appreciate the report, and I would suggest in the future, and like Mr. Waltz indicated, a comparison of what's going on in the private sector, but I also would like to see as well in comparison to the DOD, because the NCPS does use DOD information. I'm not for sure how that works here. That it seems to be not in any formal manner, but in your report you do mention in a footnote, we'll talk to designated officials, we'll talk to FDA, DOD, tissue vendors, and I'm not sure if that's any formal process for doing that. But lastly, really quickly, the non-FDA issue.
Yes.
And we don't know what we don't know, and we couldn't prove that. The recalls, obviously if the FDA is going to have a recall, it's not going to apply to non-FDA vendors in this case, and I'm not sure how you track that or even indicate you tried.
Most recalls are actually not directed by FDA. Most of the recalls that occur are voluntary recalls that are initiated by the vendor themselves. There have only been 1 or 2 instances where FDA has actually mandated that a recall occur. That's not uncommon across the board for all types of medical products. Most recalls are voluntary.
Appreciate it. I yield back, Mr. Chairman.
Our thanks to Ms. Cross. You are now excused. I now invite the final witness to the table. On our third panel, we will hear from Mr. Frank Wilton, Chief Executive Officer of the American Association of Tissue Banks. Your complete written statement will be made part of the hearing record. Mr. Wilton, you are now recognized for 5 minutes.
Chairman Kaufman, Mr. Waltz, and distinguished members. The American Association of Tissue Banks, or AATB, would not be here today if it was not for the U.S. military. The very first tissue bank in the U.S. was the United States Navy Tissue Bank, which was established in 1949 by Dr. George Hyatt. In 1976, Dr. Hyatt and his colleagues helped found the American Association of Tissue Banks. Recognizing the increasing use of human tissue for transplant, these individuals saw the need for a national organization to develop standards, promote ethics, and increase donations. Beyond the historical significance, AATB-accredited tissue banks continue to focus on the needs of veterans. As you may know, many military personnel serving in Operation Iraqi Freedom and Operation Enduring Freedom have received severe burn injuries due to the use of IEDs. If necessary, donor skin may be used as a life-saving dressing. AATB-accredited tissue banks have helped ensure that veterans have access to these life-saving dressings, as well as other biological implants necessary to relieve pain, restore mobility, restore sight, and save limbs. With that in mind, thank you for the additional opportunity to come before you today in support of the Biological Implant Tracking and Veteran Safety Act of 2014. This critical legislation directs the Secretary of Veteran Affairs to adopt a standard identification system for use in the procurement of biological implants by the Department of Veteran Affairs. By building upon the success of the implementation of the Unique Device Identifier, or UDI, this legislation will ensure that biological implants used within the department can be appropriately tracked from a human tissue donor all the way to the recipient. This critical capability for track and trace efforts will enhance patient safety, expedite product recalls when necessary, and assist with inventory management and improve overall efficiencies. This legislation takes a bold step to expand the UDI to all tissue products. In addition to human tissue devices, which are already covered by the UDI, the legislation adds another product category, certain biological implants, or, as termed by the Food and Drug Administration, 361 human cells, tissues, and cellular tissue-based products, or HCTPs. While many of the biological implants do have company-specific barcoding information, by requiring a standardized format for those barcodes, as outlined in this legislation, it will be easier for the Department of Veterans Affairs medical facilities to utilize universal barcoding conventions and to realize the full benefit of a unique identification system. Finally, by applying a system which has been developed for devices to biological implants, such a solution should also be applicable to other healthcare settings and other healthcare systems, such as the Department of Defense healthcare system and the private sector. While I understand the committee's skepticism in requesting VHA attempt a Vitus-like enterprise in this legislation after failing to do so before, I would note that a lot has changed since 2008 when the VHA first envisioned Vitus. First, there is now a UDI benchmark, which allows those developing the necessary software for data capture to move from a design incorporating dozens of barcode technologies to only 3. In addition, the VHA is not alone in trying to develop a system for integrating UDI-like information directly into the medical record. For instance, the Office of the National Coordinator for Health Information Technology is currently focused on ways in which the UDI can be better operationalized to ensure its adoption into key standards. As part of those efforts, ONC is initially focusing on implantables, the very focus of the legislation we are discussing today. Therefore, the VHA will not be attempting to establish such a system alone, but can partner with other governmental entities to ensure its success. For those of you unfamiliar with my organization, the American Association of Tissue Banks is a professional, not-for-profit scientific and educational organization. It is the only national tissue banking organization in the United States, and its membership totals more than 125 accredited banks and approximately 850 individual members. These banks recover tissue from more than 30,000 donors and distribute in excess of 2 million allografts for more than 1 million tissue transplants performed annually in the U.S. Finally, when I last discussed this legislation before the committee, I noted my concern that the draft legislation lacked a requirement that biological implants purchased by the VHA be subject to appropriate accreditation standards. It is my understanding that those concerns have been addressed in the latest version of the legislation by requiring accreditation by AATB or a similar accreditation organization. Thus, with this change, the VHA will be joining the ranks of leading medical centers of excellence, which currently require all tissue to be sourced from AATB-accredited tissue banks. AATB strongly supports this legislation and urges the committee to favorably report it out of committee. This ends my prepared remarks, and I'd be happy to answer any questions.
Thank you, Mr. Wilton. Mr. Wilton, is it common for biological implant vendors to receive FDA warning letters?
No, in fact, it is fairly rare, Mr. Chairman. We went back and looked back to FY 2000, and there were 43 recalls that were issued within that roughly 15-year period. To put it in perspective, the FDA, looking at all the different areas it has jurisdiction over, issued 45 in January of this year alone. However, it is a very serious thing that our banks take with the utmost concern.
Mr. Wilton, what is the benefit of the UDI or a standard identification system for VHA?
As I remarked, Mr. Chairman, in my comments, it is largely due to tracking and tracing, so we can take it from the donor all the way to the recipient. I think from the VHA's perspective, it'll be helpful from inventory management to be useful if there is in fact a recall, and to overall improve efficiency within the VHA system.
What are some concerns with the use of tissue distribution intermediaries?
Sure. TDIs are sort of on the back end of the system, if you will. We went back and looked at FDA registration data, and as best we can tell, only about 16% of the TDIs are in fact accredited by AATB. So the question becomes, are they maintaining the standards they need to in order to make sure that the tissue is stored appropriately and it is distributed appropriately? So the short answer is we don't know for sure. Only the ones that we accredit can we speak for.
Mr. Waltz.
Thank you, Mr. Chairman. Thank you, Mr. Wilton. Just two quick ones here for you. From your perch on this, and you've been hearing some questions as you've been here, how does the VA look compared to those other centers of excellence you're looking in terms of where they're going in this?
Yeah, I think this is a terrific effort, and as I said in my testimony, we hope that once this is implemented, it can get beyond the VHA to DOD and into the private sector. I think the big change is our tissue banks track and trace all their tissue, but there's a lot of different barcoding systems. With the FDA's guidance, there will now be 3, and I think it'll be much easier for the VHA to implement those systems and then hopefully go much beyond that.
And that will hold true both in the private sector also for them to follow that. So, so this will help. Will this help lead and push into that?
Absolutely. I think it's a terrific step for the VHA to take the leadership role in this, and we're happy to work with them.
That's great. And from today's testimony, what did you hear that most concerns you, if there's something you could hear amongst this testimony? Is trying to educate us and understand some of what...
Sure. I mean, again, the good news is, the FDA registration issue is one that clearly concerns the committee. AATB accredited tissue banks are registered by the FDA. You had some concerns about the frequency of inspections. When you're accredited by AATB, we actually go in and there's a 3-year period where we come back in, we re-inspect. So between the FDA and AATB, there are many more inspections, and we just think that our veterans deserve the best, and we feel strongly that AATB accredited tissue banks provide the best.
Okay, because what you're hearing, and I hear when it got explained further, we're always going to err on the side of cautiousness towards our veterans. So when we hear that there's a possibility, I think my colleague was bringing up a good point. I understand it's not proving the negative type of situation. He was just asking, you can't in all 100% confidence tell us this is happening. That concerns us. So I think it's important for us to understand what those steps are and how they're there and how we make that clear as we go back and assure our constituents that they're protected. And so with that, I yield back.
Thank you, Mr. Waltz. Mr. Huelskamp.
Thank you, Mr. Chairman. Mr. Wilton, your association, is that the entirety of the industry, or are there some other competing associations?
I'm not aware of any others. And,
Okay.
in doing the analysis, we feel that about 92% of all the tissue that is recovered and processed in this country is done through AATB accredited tissue banks.
And the other 8%, is that through another accredited organization? Or
I'm not aware of another organization.
Okay. What happens in that 8% then? Can you describe that? Or no one knows? Is that
I think you're correct, sir. No one knows.
Okay, okay. In your experience, I asked a question of both the previous panels. Are you able to compare the VA compared to, say, the DOD or other federal agencies? And can you describe that comparison, what it looks like, and for the committee?
I think there are challenges in all healthcare settings once the tissue actually gets to the consignee, the hospital or the doctor. We feel very confident that because it's very important for the tissue banks to know that. I think it's a universal problem, and as I said earlier, I think it's terrific that the VHA is considering taking a leadership role in this.
So does the DOD track this? Do they have an informal tracking system? Do they have a formal tracking system? I
My
presume
understanding-
that's the largest, next largest system,
Yeah, my understanding is they do it the same way that the VHA does,
which
which
is
is sort of again, it's a manual process, not a barcoding process. So having it in an automated sense, I think will make great strides for both
Is it-
DOD and.
Do you believe is it standardized and manual or?
As I alluded to, there are going to be 3 different systems that the FDA has approved to track and trace. And I think the VHA and DOD will be able to adopt them, and our members will obviously provide those as well.
Yeah, and my concern wasn't so much necessarily with the manual aspect of that. It's the fact that in the VA, it was not standardized.
My
Well,
understanding is
it-
it's not, sir.
Yeah, and it was informal, which means it's not formal. But is the DOD, in your opinion, is it informal as well, or?
My understanding is that they operate on a similar fashion.
Okay, well, that's particularly troubling. So if there's a recall, how does the DOD handle that?
I'm not aware of that.
You're not
sir.
aware? So I presume you have members that work with the DOD. I'd appreciate some follow-up on that from you, or how they handle that.
We'd be happy
I
to.
know we're talking about the VA, but if we're going to talk about that, you think the VA system that they're talking about implementing, it would be the best, that raises a concern with me as well. Mr. Chairman, I yield back. Thank you.
Thank you, Dr. Rowe. Mr. Walton, thank you so much for your testimony. You are now excused. At this time, I'd like to give VA, if they would like to respond to any of the comments in the prior 2 panels. Okay, seeing none. Today, we have had a chance to hear about many problems occurring with VA sourcing, procurement, and tracking of biological implants. From the testimony provided and questions asked today, I am alarmed at the great risk of harm our veterans face when they receive a biological implant from the VA. As such, this hearing was necessary to accomplish a number of items: to identify the reasoning for VA's questionable procurement and tracking practices involving biological implants, to require VA officials to explain their inadequate response to these obvious deficiencies, and to determine what steps are being taken to correct these issues and improve the care provided to our veterans. I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered. I would like to once again thank all of our witnesses and audience members for joining in today's conversation. With that, this hearing is adjourned.